Well, hello, everybody. Today I get to say, well, good morning from my side of the world, although I know we've got people calling in from all time zones. And we just want to say welcome to this second webinar in the PMNCH Virtual Partners Forum webinar series. One second. Oh, perfect. We are so glad you are here today. We are going to be talking about challenging questions of accountability. But before we dive into this topic and getting to know our speakers, just a few announcements. We're working on getting people connected and their audio connected as they log in. We'll continue to do that in these next couple of minutes so that everybody can hear. But you will have noticed that when you logged into this webinar, you are automatically put on mute. And we just want to say, please stay on mute for this session. It helps keep the background noise to a minimum so our speakers aren't distracted during their presentations. While we want your audio to be on mute, we certainly do not want you to be silent. We'd love for you to use the chat box as speakers are presenting. Ask your questions via the chat box. You move the send to everyone. That way everybody can be part of this dialogue. Make your comments, ask your questions. When we get to the Q&A portion of our webinar, we'll be starting in the chat box here and looking at those questions. So please feel free to do that. And just to help you get used to this software and to make sure that everybody's starting to get to know who we are and our experience, well, you've joined Claudia, who's already started in the chat box by typing in who you are, where you're calling in from, just so we get to know who our participants are today. That would be most excellent. Oh, thank you, Sheila, for typing in your introduction. Perfect. So you are here as part of the Virtual Partners Forum for PMNCH. Our webinar series is a 5-part series that will help you get to know the themes that we are exploring in the PMNCH Partners Forum happening in a few weeks in Delhi. But we know not everybody can make it to Delhi in December. So we want to bring the December forum to you virtually. You can join partners in their site events that they're opening up virtually. You'll see the PMNCH plenary sessions via live streaming on our Partners Forum 2018 website. And you'll get to know the different panelists via our website. And we hope you'll be engaging with PMNCH throughout the next several weeks on Twitter and other social media platforms. All of that information, again, can be found at the forum, and we'll put that link up very, very soon. So as I said today, we're talking about accountability. Oh, we'll get to that in just a minute. And one of the co-chairs of the accountability theme for the Partners Forum is my colleague at World Vision International and a mentor of mine, Dan Urban. So Dan has directed the Health and Nutrition Department in World Vision International since 2007. And he's had many roles in accountability. During this time, he has advised development of interventions and programs focused on primary health care in developing, fragile, and humanitarian contexts. He has led a health system strengthening approach from the community perspective, resulting in the support of 220,000 community health workers. He's an advocate of social capital, social accountability, and has advised the development of World Vision's core local level advocacy approach, as well as its global campaigns focused on maternal and child health and nutrition and violence against children. He's also been working very hard with his partners in this Partners Forum to put together our wonderful panel that we have today. Dan, I am going to hand it over to you for proper introductions of our speakers and of this theme in general. Let me pass you the ball and continue as you are ready.
Thank you so much, Sarah. I'd like to extend a very warm welcome to all of our participants today. Thank you all very much for joining this discussion, which, as Sarah has pointed out, is focused on accountability. As you all likely know, accountability for women's, children's, and adolescents' health is a prioritized theme in the upcoming PMNCH Partners Forum event, where there will be a focused plenary session on accountability and 6 concurrent sessions on accountability as well. Tees Borma from Countdown 2030, Miriam Sabim from PMNCH, and myself have worked with an expert advisory group to plan out these sessions and have chosen to focus them on 6 distinct accountability perspectives. Our auspicious panel today are representing each of these perspectives, and I believe if I forward into the slide here, we're going to get pictures of them as well. So first we have Joy Lawn, who is Professor of Maternal, Reproductive, and Child Health from the London School of Hygiene and Tropical Medicine, and Joy will be speaking about the data revolution. Then we have Elisa Scolaro, External Relations Officer for Parliamentary Engagement at World Health Organization, and Elisa will be sharing with us about working with parliamentarians in governance for accountability purposes. Then we have Marta Schaaf, Director of Programs and the Program on Global Health, Justice, and Governance at the Mailman School of Public Health at Columbia University, who will be speaking about social accountability, followed by Elizabeth Mason, who is now a member of the Independent Accountability Panel after many years at WHO and the MCH department as well. And Liz will be speaking with us today about the private sector accountability. Then we have Jocelyn de Jong, Professor and Associate Dean for Academic and Faculty Affairs at the Faculty of Health Sciences at the American University of Beirut, Lebanon. And we apologize to you all. We had Marco Schafferhoff lined up to talk about the role of accountability in health financing, but unfortunately, Marco just had a slight accident and will be unable to join us. I think that you will all agree with me that we have an excellent panel. We're very fortunate to have them with us today. The panelists, as I just noted, will be speaking to 5 of these 6 themes. We won't get to the finance piece. And we've asked for them to address 3 principal questions. The first, why is accountability from the perspective of their theme critical to achieving the global strategy for women's, children's, and adolescents' health? Secondly, what are some of the key challenges they see currently facing this specific accountability objective? And thirdly, what are some quick examples of solutions that we might recommend to be scaled up? Now, I will share with you all that we thought hard about what best to address in a 90-minute virtual pre-forum call, and we landed on these questions because we recognize that it is not enough time today to go into great depth across these themes. We didn't want to pick one or the other. And again, these 6 themes are the themes that have been chosen to structure the plenary session at the Partners Forum, as well as the 6 concurrent sessions. So we're hoping that today's discussion will pique your curiosity, will raise some critical questions, which we will then revisit with a little bit more time at the forum event itself. And we hope that we will have a little bit of time today also for some of your prioritized questions when we get to the end of the 5 panelists' presentations, and we'll have some discussion, and then we'll take it all up again at the forum itself. Before I turn over to the panelists, however, I'd like to just lay out a couple of the principles around our thinking as we've gone into the design of this track of the forum. Firstly, accountability surely describes the relationship and responsibilities between duty bearers and citizens. Duty bearers can include government, but not only government, also the private sector, other service providers, and citizens themselves. We use the term citizens carefully as it's useful to describe legal rights in many cases. However, all people have human rights within and without their countries of citizenship, whether they be non-registered in their own country, displaced, refugees, or migrants. These rights apply to all people regardless of age as well. We believe that accountability for health is founded, first of all, on the concept of health as a human right. And from a human rights perspective, we understand that people are not passive beneficiaries of resources, but rather active agents with entitlements who can make claims upon governments and other entities to fulfill their obligations. A human rights approach to health requires that the people who are affected by laws, policies, and programs have an active voice in formulating, designing, and evaluating them. As we're talking about human rights, I wanted to just point out a starting point around them from the Universal Declaration of Human Rights, which is our most common benchmark. Just to remind you, and Article 25 of the Declaration lays out the human rights to health with emphasis on mothers and children specifically. Secondly, I'd like to point out Article 21 as well, which eloquently describes our right to participate in our governance, to access equitable services, and that it is the will of the people that forms the authority of government. So let's look a little bit at the fundamental process of accountability as we've been working with it. Here in this slide, we have the simple three-step process that the Every Woman, Every Child Independent Accountability Panel have used as the basis for their annual accountability reports, and that we have subsequently used as the basis for our thinking on the accountability sessions. A three-step process: monitor, review, and remedy. These are fairly self-explanatory as logical steps, and I've highlighted here in the slide some of their characteristics for you. While these steps are fairly logical, we know that the work and investments that go into each of them are not that simple, and in fact are where we have a lot more work to do to realize the global strategy for women's, children's, and adolescents' health, which is where our excellent panel today comes in. So allow me to turn our presentation now over to Joy. And as we do, I will be happy to begin to take any questions or clarifications that you may have in the chat box. Otherwise, we will be holding on your questions until the 5 panelists have completed their short presentations, and then we'll get into that. So thank you all very much.
Thank you, Dan. This is Joy Lawn here. Can I be heard okay?
Very well, Joy.
Okay, wonderful. So good morning, good afternoon, everybody. Welcome. I have the privilege of following Dan, and I am here both as a professor from the London School, but also from the Countdown Initiative. And the topic that I have is on data. Do data matter for accountability? Is the data revolution out there happening or not? And how will that help us to be more accountable? And I haven't put any slides making the case for the need for data, because if you look at the word accountability, count is the heart of it. And if you take count out of accountability, what's left is nonsense. So it's absolutely fundamental for everything that we do in accountability that data are at the heart of that. And that may be quantitative data around progress towards targets, or issues around rights or coverage or equity, or it could be qualitative data on experience of care or issues around perceptions or exclusions. So moving on to the next slide, I have taken the two themes that we're really going to take forward at the PMNCH forum on data. First of all, do we have the data that we need to act? So what was just being explained by Dan about that interaction between citizens and duty bearers. Do we have the data that we need? And then of the data that we have, are we acting on that? And if we think about where we were in the MDG era, where we were focusing on targets, where we only had 8 Millennium Development Goals, and we had a very privileged position for health, and particularly privileged position for women and children, and where most of the targets were really based on deaths or on provision of specific care, skilled attendance or family planning or immunizations. It was a much more simple environment in many ways. So we sometimes joke that those 8 Millennium Development Goals were probably made up by a bunch of white men in a room in New York, maybe mostly economists. But it was a very different discourse for accountability. So the discourse was that if you succeeded with health, you were likely to get development. So there was a large number of health goals, and it was seen that the result would be development. Whereas in the Sustainable Development Goal era, we have 17 goals correctly set by countries. And with that, we can also see that the discourse has flipped. So much more of them are about broader economic development, urban settings, climate. And we have one goal on health. So this is both an opportunity and a risk for us as regards data. So the opportunity is that we have linkages, and one of the other webinars in this series is looking at intersectoral linkages, which are critical, important for health, important to drive accountability more broadly than just within a narrow sphere of health, but also more challenging for the data. So if we look at these 17 Sustainable Development Goals, we have 169 targets across them. And even within the narrower health goal of SDG 3 on well-being, we have at least 13 targets, and that's probably cheating because underneath them there are quite a few extra ones. So we have this shift from a much smaller number of indicators to guide us and to have data on, to a much broader. And in many of the assessments of the availability of data, it's highlighted that probably only a third or less of these 169 targets have data that are available in 2/3 or more of the countries. So we have a gap. And within that, we have additional levels of ambition, not just in tracking more targets, but also in shifting that from just being global tracking to not just national, but to subnational, and to actually using that locally and linking it very much to action, going beyond the averages to data that really ensure no one is left behind. So not only do we have these large number of targets, even if you just focus on the 13 for health, but if you want to disaggregate those by, for example, gender or urban-rural or equity quintiles or specific age groups such as adolescents or newborns that are left behind, then we have lots of stratifiers that mean we have even more challenges in how we take that data forward. So the critical thing for the forum and for progress for women, children and adolescents health worldwide is particularly the global strategy. And this global strategy will be the highlight and focus of the forum. and has 3 pillars: survive, thrive, and transform. And again, if you look at those pillars, we're probably stronger on survive, a bit weaker on the data we have on thrive, and it's much more challenging on many of the constructs around transform, where we're trying to transform health systems, measure universal health coverage, and also look at transforming social norms and inclusion. So if we look at the data that we have for survive, and somehow this slide isn't moving forward, okay, we have a clearer picture of deaths. And around the world, even though we made remarkable progress during the SDG era, we still have a major challenge with maternal deaths being at more than 300,000, child deaths after the first month of life being 2.8 million, newborn deaths being 2.5, and stillbirths also being more than 2.5 million. And in this SDG era correctly, where we've brought in the adolescents, not just to the title of the global strategy, but also into our data tracking. And I think we should be congratulating UNICEF and the UN IGMI report for bringing adolescents and children over the age of 5 into the data in the latest report out last month. But if you look at this in total, on the survive agenda, we still have 10 million deaths of women and children and adolescents. And 50% of these are particularly stacked on the time period of pregnancy and around the time of birth. Shockingly, 1.3 million stillbirths happening during labour and 1 million babies dying on the first day after birth, their only day of life. So the deaths are still huge. And as we move forward, even though we like to think that we have all the data that we need for survive, we have many gaps, and particularly in the highest risk places, for example, humanitarian settings, there are many gaps. So I want to flag this principle of Finnegal's laws of information, because we won't be able to collect every single piece of data everywhere. If you're in Norway, you may have about 2 million data points by the time you're a week old. But in most of the rest of the world, we still hardly have birth and death certificates for everybody. So it's critical for us to say, what information do we need? And in the last century, there was a very pessimistic Scottish man called Finnegal, who had these very miserable set of rules. The information that you have is not what you want. The information you want is not what you need. What you need, you can't obtain. And even if you could, you couldn't pay for it. Well, I think for us in the SDG era, and particularly if we want to have the data that will drive accountability and change, we need to be clear what information we need. We can't have all information, but what do we need to drive change? What information do we already have that we can use now? What information do we not have that we need to be ambitious and make a priority of obtaining? And particularly, we need to think from the beginning, how could we integrate that into routine systems? So where the world is in a data transition phase, and we still have many countries dependent on surveys. But as we move forward, we also need to be building routine systems, birth and death registration, and health facility data systems. So if we could answer these 4 questions, what do we need, what can we use, what must we obtain, and how can we integrate this into routine systems, we could see rapid change in data that we have and can use. So I want to finish with some questions and a couple of sidebar examples. So do we have the data that we need? Well, clearly, we don't have all the data that we need to act, but what are the priority gaps? And there are some very large burden conditions where our data still are considerably weaker than in other areas. So in areas where maybe we've been more ambitious and intentional in our data collection, HIV or immunization, we can really say who's left behind, what's happening, what's the quality, who's dropping off in programs. But in adolescent health, and maybe particularly in stillbirths, we've had very little intentional focus on collecting the data that we need. And one fantastic recent example is stillbirths. There are actually 157 of the 196 UN member states that do collect stillbirth data routinely, but they've never been asked for that from the UN. So this is an example where accountability now has led WHO to start asking for stillbirth data from countries just from last year, and being able to collate that. And UNICEF and WHO are working together, we hope, also with IHME, to generate better stillbirth estimates based on a better link with accountability in countries. And then finally, do we act based on the data that we have now? Well, one of the challenges for many people at the coalface is that we collect monstrous amounts of data, and some of that goes up the system, but often it doesn't come back to people who are using the data directly to improve programs where they are. And how do we make that better? So it'd be lovely to have examples from people, maybe here, on data that have been used for local accountability at the facility level, or else further passing up the track, but still coming with communication that is two-way to lead to change. So I hope that these questions will stimulate conversation now and also as we go forward to the forum in the next few weeks. And I would like to pass over to the next speaker.
Hi, everyone. I want to make sure you can hear me.
You're very faint again. So again, as loud as possible.
Okay, so I'm going to talk what seems to me to be very loud. And please feel free to let me know in the chat box if it sounds like I'm yelling in your ear. So hello again. I'm happy to be here to present alongside my colleagues about social accountability. Many of you have likely heard the term social accountability before. In fact, in looking at the participants list here, I'd say that a lot of you are actually experts. But in any case, I wanted to make sure that we're all on the same page, and so I'm going to start with a definition. Sarah's telling me I'm still quiet, so please, others, feel free to give me some feedback on how loud I am or how well you can hear me. Social accountability can be defined as ongoing and collective, and this notion of collective is very important. Efforts to hold public officials to account for the provision of public goods which are existing state obligations or that are consistent with socially accepted standards and norms. So by socially accepted standards and norms, I'm referring to things like polite treatment of patients, which may not be reflected in formal guidelines, but everyone agrees is necessary. Social accountability efforts generally have three key components. The first is an agreed set of standards against which collective actors, usually members of the community, assess performance. The set of standards can include laws, policies, or Ministry of Health guidelines, for example. The second component is discussion of information about the actions the state has undertaken, usually the state. Collective actors might discuss facility data or data stemming from a citizen audit of a health facility, for example. The third component includes governmental actors justifying and explaining their performance. Justification often occurs in interface events that bring actors in the health sector, such as health providers, managers, and decision makers, together with the community. At these meetings, participants discuss how the information that they've collected or that they are looking at relates to the standards. In other words, how does health facility performance stack up? How close is a health facility to meeting the standards? Most social accountability efforts include multiple opportunities for interface, such as these. Though these interface events can be adversarial at times, in general, such meetings actually build trust between communities and the health sector. Often, the community and the health sector will work together to agree on priority actions they will take. Examples of common social accountability approaches that you've likely heard of include social audits, community monitoring, and community scorecards. social accountability can help us to realize objectives related to women's, children's, and adolescents' health. First, it can be a mechanism for realizing or for helping to realize country and global level accountability for EWAC, for every woman, every child's goals. And it's also a potentially effective way of ensuring community engagement, which is an EWAC action area. So here I outline 5 key challenges to robust, scaled up social accountability efforts in maternal, newborn, child, and adolescent health. First, I think it's important to point out that though there is a well-established field of social accountability in development, the use of social accountability approaches is somewhat new in health, or at least the use as it's reflected in peer-reviewed and gray literature. As a result, there remain important questions about when and how the health sector responds to citizen priorities, how NGOs and other actors can support both social accountability efforts and governmental capacity to respond to citizen priorities, because sort of expressing, making demands and expressing voice is not necessarily useful if it doesn't result in a state response. And also how and when governments can support robust accountability processes. There can be, of course, an inherent tension in the notion of a government leading an effort to hold itself to account. So what kinds of roles governments may play, in which context remains a subject of discussion. Second, in the health sector, most existing social accountability programs are bounded local level projects. In other words, they might focus on 1 or 2 health facilities or on all of the facilities in a limited geographic area. There are fewer documented examples of projects that engage multiple levels of the health system, meaning health facilities, district, state, or province level decision makers and managers, and national level technocratic or political actors. Third, in some contexts, poor quality care may be normalized among both providers and patients. Community members don't necessarily know what their rights and entitlements are, while providers may have become accustomed to working in a poorly resourced system that lacks basic materials and staff support. Fourth, in some contexts, citizens pointing out certain kinds of gap in the health system can face risk, such as being denied care at the health facility in the future. Providing information to community members about their entitlements is not necessarily enough. Community members may require support and accompaniment to discuss challenges they face in accessing health care. And lastly, there are few models of social accountability that encompass the private sector, which is an increasingly important provider of services in many countries. And I know my colleague Elizabeth Mason will elaborate on this further. In theory, the government should regulate the private sector, but collective efforts to hold the government accountable for private sector regulation is clearly a more complicated endeavor. So this is my last slide. Social accountability can address some widely shared priorities. First, the recent Lancet Commission on Quality highlighted the significant scope of the healthcare quality challenge we face. Social accountability can address patient-defined elements of quality of care, such as respectful treatment, provider absenteeism, and increasing family planning commodity availability. Second, as I noted, opportunities for interface that accompany social accountability efforts often improve community knowledge about the obstacles providers face and vice versa. Providers and communities can learn that they have some shared priorities, such as improved supply chain or getting more human resources. These shared priorities can be a basis for cooperation. As I mentioned, there are few examples of scaled up efforts, but looking at the field of social accountability within and beyond health, there are a few lessons that we have already. First is to acknowledge the potential role that national level NGOs can play as an intermediary. For example, in the Philippines, the Scouting organization undertook a project called Textbook Count, wherein scouts at all levels, multiple levels of the supply chain, monitored the provision of textbooks. The engagement of NGOs with a national reach can help to ensure that a social accountability program weathers changes in political power, so it's somewhat separate from the government, and help to ensure that it does not become a top-down box-checking activity and remains community-driven. And that, of course, assumes that the NGO has some community constituency and is sensitive to community needs. Second, in contexts where entities exist that link communities with the health system, these entities can provide an infrastructure of sorts for social accountability efforts. For example, village health committees and community health workers may be able to support social accountability efforts, such as by liaising between community groups and the health sector. There are multiple examples of village health committees being trained as part of social accountability efforts, and they can play an ongoing role in implementation. I hope during the Q&A we'll have more time to hear about some of your particular experiences with social accountability on the ground. Thanks.
Thank you, Marta. Eliza, I have given you the presenter ball. You are unmuted and start as you are ready.
Thank you. I'm fine. Dear all, I'm pleased to meet you all, even if only virtually, for a brief introduction on the concurrent session and topic that we are going to have at the upcoming PMNCH Forum on the role of parliaments. My name is Elisa Scolar. I take care of parliamentary engagement within the new WHO's cluster of external relations. And we have been asked to co-organize this session at the PMNCH Forum together with some key partners working with parliaments, the Interparliamentary Union, the European Parliamentary Forum. As you all know, accountability is one of the core functions of parliamentarians. Parliamentarians have indeed the responsibility to promote the highest standard of health and well-being for people through their core functions of legislation, oversight and accountability, budgeting, and advocacy. They play an essential role in enacting legislation, harmonizing laws that already exist, and eliminating those legal barriers that prevent access to health. But they have also key decisional power on approving budget allocation that can be crucial and define somehow the capability and efficiency of a country in delivering on health. The role of Parliament is also critical somehow in terms of advocacy and in influencing a country direction and vision to achieve national and global health goals. But above all, as we all know, parliaments have the responsibility and authority to keep government accountable for commitments taken and to oversee the implementation of national decisions and global agreements. They have the unique constitutional oversight functions. They are the only actor with a political mandate from the people, basically to monitor the management of the state by the government. The role of accountability is somehow less understood and a little bit underestimated, a specific field of the activity than Parliament's other core tasks like in lawmaking and representation. But it is instead crucial, and somehow with this session and with this discussion, we would like to call for more attention on how this needs to be linked to government, to citizens, and to the international community. Accountability has specific aims. It aims at improving governance, assessing the impact of government action on society, and ensuring that appropriate resources are allocated to implement government's program and to meet national and international commitments. I like always to use a description from the latest Interparliamentary Union report on oversight that says basically that oversight and accountability are major dimensions of the complementary democratic mandates of government and parliament. Governments provide services to citizens, and parliaments hold governments to account by questioning and challenging their actions and policies and making recommendations for change. And this is basically why we are going to have this session within the PMNCH Forum, to just try to discuss on what could be concrete role for parliaments in keeping government accountable for women, children, adolescents, health, and just trying to understand what are successful and efficient accountability mechanisms that are already in place and how we can learn from them. But as you know, in this, there are for sure some challenges that parliaments meet in carrying out these accountability tasks. And the first that we always highlight is access to the right knowledge and evidence. The key and most important challenge is this, because while adopting legislation or allocating specific budget, MPs need to heavily rely on evidence. And to make the right decision, we need to make the right evidence. Sorry, and to make the right decision, they need to have the right evidence, which is strictly linked to the second point, which is the translation into evidence. Once MPs get the right information, it's crucial to have this directly inform the political action. We have seen too many times making generalization from anecdotal reports or from very weak data in order to find a way to deal with uncomfortable truth. Access to the right information is vital to promote evidence-based political action, and it would be important to discuss somehow mechanism on how this is happening and how it can be better implemented. The third point is, of course, debate with the executive, with the government, within the political space. Within this session and later on, we aim at having at inviting together with parliamentarians also representatives from government to have somehow the perspective on how this dialogue is happening. We know that there are several and different mechanisms set for the parliament to question the government decisions and to provide guidance and recommendation on how to proceed. But we also know that this is happening within the real life, and that this dialogue can be influenced by political positions and the general political environment. And then, of course, parliamentarian needs to deal with the existing structures and processes. There are several formats through which parliaments can ensure accountability. They can work in committees, which is the major focus for parliamentarians, but again, this is of course influenced by the composition of these committees, powers, resources allocated. And then there are the opportunities in the plenary context, where of course there are a number of possible procedures such as motions, questions, interpellations, financial oversight. The fifth point I'd like to highlight is of course, the link with competing budget allocations. Again, parliamentarians, they need to choose within multiple options, and they need to link these to their political agendas. Now, after what we heard from the previous presenter, I think we are all convinced that it is not possible to separate the action of parliamentarians as per the core mandate from social accountability. Civil society organization, audit agents, public interest group, the media can offer a range of resources, and that cannot be disconnected from what is the parliamentary action. But as we know, this is not always happening. And of course, the final point is what I call political choice, because all we mentioned so far, of course, depends on political choice. MPs might overcome all the challenges we just listed, but still make a different political choice. MPs might have the right information, might be able to translate evidence into concrete and right actions, might have good processes in place to oversee government actions and asked to be responsible for commitment taken, but this is still a political choice to be taken within competing agendas. For this reason, in the last years, we have been working to somehow highlight the critical role that parliamentarians can play within the women, children, adolescents health at national, regional, and global level. At the event, as you will see, we will have representatives, parliamentarian representatives from these two key partners, the Interparliamentary Union and the European Parliamentary Forum, that will give you an example on how this has worked so far. We know that important steps has been taken in the engagement of parliaments in the process, for example, at the regional development of the global strategy for women, children, adolescents health, where MPs have been for the first time ever in a systematic way, engaged in the different phases of the consultation. This has led, for example, to the interparliamentary commitment to the global strategy and their follow-up participation to the high-level discussions in panel. These are somehow critical opportunities for scale up that have been created. And now we are looking forward at new opportunities. In my slide, I just wanted to mention what, for example, the Interparliamentary Union has had developed so far. In 2012, we managed to have a first resolution, IPU resolution, to position the issue of women, children health within the IPU agenda. And now, last month, basically, we had the approval by the Committee on Democracy and Human Rights of the IPU for the IPU to work on a new resolution on universal health coverage and how women, children, and adolescent health should be central within the universal health coverage agenda. These are somehow some of the opportunities for scale up that I wanted to mention, but we will be very pleased to open the discussion at the PMNCH forum to learn from existing experience, from existing mechanism for accountability, and somehow to stimulate a better engagement of parliamentarians within our health forums. Thank you very much.
Celine, you have the ball, but we're not hearing you yet.
Yes, so I don't see the slides, so as soon as the slides come up. But so my name is Jocelyn de Young, and I'm talking to you from Lebanon at the American University of Beirut, and I'm very pleased to have this opportunity to speak in this webinar about an issue that's of critical importance in the current age. So this is a question of accountability for women, children's, and adolescents' health in conflict settings. So I'm a member of the Countdown as well, and I'd like to follow up with two themes which have been touched on earlier in this webinar. The first one that was mentioned by Dan at the beginning, that when we talk about health and human rights, the first issue that we face is that many people are not citizens, so we're dealing with non-citizens who are in other countries, often because of conflict and forced displacement. And I also want to pick up on the whole issue that Joy was talking about the lack of data, because it's in humanitarian settings that we often have an acute lack of data on which to base our interventions. So the first thing that I'd like to point out is that, of course, the numbers of people affected by conflict and forced displacement globally are growing for a number of reasons. The first one, of course, is that the scale of conflicts is growing. And secondly, that many of these conflicts are protracted. So if we look at the Syrian conflict now in its 7th year, of course, this has contributed to a huge amount of displacement, which I'll come back to in the following slides. But if we look globally, 68.5 million, according to UNHCR data, of people forcibly displaced worldwide. And not commonly known, but the largest number here is actually of the internally displaced. And then this is followed by refugees and finally asylum seekers. But these are the people for whom we have data. Of course, there's also undocumented migrants and others many other people for whom we don't have data. So, second reason why this perspective is so important is that particularly when we look at recent conflicts, they're no longer the interstate kind of conflicts involving exclusively the military, but what we're actually seeing is much of the fighting taking place in highly populated, often urban areas, which are entailing much greater civilian losses. And of course, this has clear implications for women and children. They're also, unlike the historic pattern where many of these conflicts were taking place in low-income countries, what we've seen in the last decade at least is that many more conflicts are taking place in middle-income countries. And by the same token, many of the low and middle income countries are the ones that are actually hosting the greatest burden of refugees. And the majority of these are women and children. And so if you look in the case of Lebanon, the country that I live and work in, about 75% of the Syrian refugees in Lebanon are women and children. And we also know from the evidence historically and in present day conflicts that conflict disproportionately affects women and children. Part of the reason for that is that these are the very people who need a very stable health system for delivery and for immunization and all the other issues that we're concerned about. And so when that stable health system is disrupted with the loss of manpower, the loss of supervision, the loss of the breakdown, even the attacks on healthcare system, women and children are often the first to be affected. So of course the primary reason that we're all here also is that when we're thinking in terms of progress towards the SDGs, these are countries which are often not making progress. They're often countries which are going in reverse, and the progresses that they have been making have been completely undermined. And so when we think of targets, for example, like the universal health coverage, what does that mean in a context where the health system has been completely undermined? It's not just a question of reaching people, but trying to rebuild the whole healthcare system. So in terms of some of the challenges that we have looking at the accountability for the well-being of women and children and adolescents in these settings, the first one is, of course, many of the people who are most acutely affected by conflict, are on the move. So these are mobile populations that are very difficult to reach through services and through data collection. They also flow over national borders. So this is just a map showing from some work we've done trying to track the effect of conflict, the Syrian conflict, on the health of women, children, and adolescents across the continuum. And what this shows, this is with Syria here in the middle, the size of the pie is the number of people affected. And we also give a ratio here to the original national population of that country. So you can immediately see that the largest pie here is in Syria, and these are the internally displaced within Syria, the people who have been affected internally and have not yet, for various reasons, left the country. And then you have the other pies in the neighboring countries, of course, showing a huge burden on those countries. And again, bearing in mind that these are women and children who need access to health, to education, to social services. This poses a huge burden on those countries. So now in Lebanon, about 1 in 4 of the population is a Syrian refugee. And this is added to other flows of refugees from other historical conflicts. So the way in which these refugees are absorbed into the different countries has a huge impact on what we see in terms of their health status. So, one of the challenges, of course, when we think of accountability is, and in a sense, the SDGs almost assume that we have functioning governments and not governments in fragile settings, which have a capacity for stewardship to actually fulfill accountability obligations. But of course, in conflict settings, that's often not the case, and indeed governments may in fact be party to the conflict itself. Then we have a proliferation of players coming into neighboring countries, to the countries in conflict, often very suddenly, and with varying lines of accountability and working on different time frames as well. So that makes the picture in terms of service delivery very complicated. And what we have found is that when we try and establish what kind of data we have along the continuum of care to actually understand the RMNCH situation of conflict-affected populations, it's a question of having to piece together data from multiple different sources, multiple different agencies, and often one has to rely on personal context because there is a lack of nationally representative or even population representative data that one can draw on. And we know, of course, that in conflict settings, it's often a question of safety, the mobility of populations, multiple challenges, which make it very difficult to collect reliable information. And then the last challenge is that, certainly in terms of the media coverage, but also in terms of research, that there's often a focus on the direct casualties of conflict for political reasons and others. And of course, those are hugely important if we're to understand the nature of the conflict. But if we really want to understand the impact of conflict on women and children and adolescents' health, it's very important for us to understand the indirect consequences of conflict, societal disruption, the economic effects, the breakdown of the health system. But of course, these are very hard to measure, and there's no consensus on exact definitions. So in terms of scalable solutions in humanitarian settings, and I guess the first message that I'd like to get across is that there is a whole lot that can be done. And people like myself who work in academic institutions, we think that we have a lot to offer as public health institutions working on these issues, working in partnership with development and health and humanitarian actors. So of course, our comparative advantage is looking at research and data, and there's an enormous amount that needs to be done in this area. And the first thing to be borne in mind, again referring to non-citizens, is that actually all states have obligation towards vital registration of resident non-nationals as well as nationals. So in the case of Lebanon, the Lebanese government does have an obligation, like other governments hosting refugees and other governments, to report on the well-being and the RNNCH situation of refugees as well as their national population. But of course, politically and for other reasons, feasibility-wise, it's often very difficult to do that. The SDGs have called for disaggregation, and of course that would include non-nationals living in countries as refugees. But we haven't yet found a way to institutionalize the responsibility for that kind of reporting. And if we look back to the to the MDGs in this region, for example, where there's countries with very high proportion of non-nationals, typically governments did not disaggregate between nationals and non-nationals. And then very importantly, and we learned this through our research on the Syrian conflict, is that there's often a lack of data standardization, even a standardization of the measures. And then if we don't have data standardization, it's often hard to have any sort of data sharing. And this has been a critical area where there needs to be much more work. And of course, when we're talking about refugees, internally displaced, and people who are fleeing political conflict, this is an area where respecting confidence and safeguarding confidentiality is absolutely key. But we know for those of us who work on data that there's ways of doing that, of protecting data confidentiality. So it's absolutely urgent that academic institutions, humanitarian actors, and all those involved in actual interventions and health systems are able to acquire data, analyze the data, and look at who's being left behind. The second point is that there's a need to think about the national health system. So again, if we're having the protracted crises as we see now in the Middle East, with countries who are now going into almost a decade of complete political upheaval, and then we have neighboring countries which are hosting substantial numbers of refugees, we need to talk about, this is not a question of short-term interventions and then leaving, that we have to think about how we can build the national health systems to help to absorb these refugees. And also by strengthening those national systems, we're of course dealing with the pressing problem of the health system deficiencies for the whole population. And that would rectify, or at least start to address, some of the political issues that often arise in countries hosting large proportions of refugees. And then the last one, which may seem more idealistic, but I think there's a growing movement worldwide to think about ourselves and our role as public health practitioners and academicians and analysts in thinking about how do we document sometimes the antecedents of war, so the inequalities in access to healthcare, the inequalities in health and well-being, which actually were some of the risk factors, if you like, for the outbreak of conflict. But then we have a responsibility as academicians working in public health to document the devastating effects on war. Who is more affected than others? Who was safeguarded? Who isn't? Who is paying the highest price? And I think until we are much more visible, much more articulate in providing evidence to these debates, we won't have a greater visibility of particularly the indirect and tragic consequences of war and conflict on women, children, and adolescents. So thank you very much.
Good afternoon, everyone. I'm Liz Mason, and I'm a member of the Independent Accountability Panel for Every Woman, Every Child, Every Adolescent. And in going last, I have the benefit of being able to say that everything that has been said beforehand is applicable overall to accountability, particularly of the private sector. And what do we mean in terms of accountability in the framework of the Independent Accountability Panel? you've heard a lot so far about data collection. You've heard also about social accountability and about accountability of parliamentarians and in humanitarian action. The framework that we have as the IAP looks at all levels, but looks at a circular action, looking at the monitor, that is the importance of the data, analysing what that says, and then importantly the remedies and action which have underlined the human rights framework. So without the remedies and the action, then we feel that we're not really holding or being held to account. So looking at the importance of what the solutions are and what the actions are to implement those solutions is extremely important. And noting that at every level here we are including governments, parliaments, all those providing services, but also the citizen accountability that you've heard from already. So in looking at private sector accountability, the issue is not if, but how the private sector should be involved. Why is this? This is because the private sector is already providing many services. Not only that, they actually are, it is the pharmaceutical industry that creates and manufactures both medicines and vaccines. And the food that we eat, the drinks that we drink, are actually produced almost exclusively through the private sector. So some of the issues in terms of private sector accountability is who are they accountable to? We know that private sector are accountable to their shareholders, but what accountability do they have beyond that to the citizens that buy their products, that procure their services? We also recognise that when the public sector is strong and government is responsive to its citizens, the private sector can thrive. And we have many examples in high-income countries where this is the case. We also know that under international law, governments have the obligation to ensure that all public and private sector entities meet the standard for public health. But we know that is not the case in many countries. We recognise that health is not a commodity. Financial interests need to be subordinated to the essential needs of women, children and adolescents. But in many cases, health is treated as a commodity for the biggest profit that actually can be made. So in this respect, we are looking at the expansive field of the private sector and health, but focusing in on the delivering of services, the pharmaceutical sector and the food industry. So very briefly, some of the issues in delivering services. Who is responsible for service provision? And as I've already said, although the government is responsible to ensure that the health services are provided, they don't necessarily have to provide all of those services. But if private sector provide the services, are they providing them in the way in which the government is assuming that they will be provided? One example is caesarean sections. We know that in private sector clinics, often the caesarean section rate is far, far higher than in public sector. We also know in terms of access to services that maybe in the private sector, it's often people with more money, but not exclusively. But the services are provided may not be provided across the board. And the cost and the quality of the services, unless they're regulated appropriately, may be beyond the reach of many, and the assumption that quality is good is not necessarily the case. It has to actually be monitored. In looking at solutions for this, the regulation of private sector should be a government mandate as well as regulation of the public sector. We've already heard about parliaments, and they need to strengthen the legislation and oversight and its performance. And the UHC 2030 partnership needs to drive political leadership. And we will be discussing in the forum some of those issues and the countries that are already undertaking some of these actions. Looking at the pharmaceutical industry, we know that some of the issues around the pharmaceutical industry is not only the fact that it has more than $1 billion of trade, but actually, even with that, more than 2 billion people lack access to essential medicines. And importantly, in low-income countries, 90% of the population purchase drugs out of pocket, not only with variable pricing, but with very variable quality, and the issues of how the quality of the drugs are monitored, as well as their availability, is an issue that is extremely important and will be explored. Also, the issues around price fixing and different pricing according to where the various medicines are being bought and sold. And again, key actions that can be taken to ensure equitable and affordable access to quality medicines for women, children's, adolescents' health are to strengthen legislation, to regulate the governing of the pharmaceutical industry, and to look at international and multinational trades on pharmaceuticals. I'm rushing through this because of a time limit, but the last area I would just like to highlight on is the food industry and big business, and the growing epidemic of obesity, which many are saying now is the commercial determinants NCDs, because what is in the food that is processed is often beyond the people that are actually consuming that food. The fact of we have the Code of Marketing of Breast Milk Substitutes, but we know that violations, particularly in the lowest income countries, are rampant. And we need to strengthen all of these in terms of the regulation. We have some excellent examples in all of the recommendations that you see in front of you. We have countries that have taken these forward and actually are making a difference. And in the session in the Partners Forum, we will be discussing some of those excellent examples. For example, food labeling in Chile, sugar tax in Mexico, efforts to have standards for diet and school exercise programs. And we aim to have a lively debate on how the solutions can be put into practice, and also what the private sector can do themselves to ensure that they are being accountable, and also that their fellow colleagues are being accountable, and it's not only just one or two leaders in the field. Thank you.
Liz, thank you so much. And in fact, a sincere thank you to all of the presenters, Joy, Marta, Elisa, Jocelyn as well. Just tremendous. I hope that all the participants are feeling a sense of excitement and anticipation towards the longer, in-depth discussions that we'll be having in New Delhi. Certainly, we can see how rich the accountability question is and how diverse and large it is. I'd like to thank also Asha for connecting us to all of those research document links in the chat box. Thank you so much, Asha, and Marta as well for putting in some links there. That's super helpful. I'm sure everybody has appreciated that as I have. I will say that we have not seen really a single question in the chat box. It's been all expert contributions, and I think we have a very expert group of participants on our call today, which is wonderful as well. But here's a first question from Asha in the chat box now, and Jocelyn, I think that we can direct this question to you. Asha's question is, what are the accountability mechanisms that hold donors and NGOs in conflict settings?
So, I mean, I focus more on the issue of data and research in what I was talking about. I mean, from the perspective of living in Lebanon on the edge of the Syrian conflict, one of the things that we have noticed and observed is that the government, the Lebanese government, is often not aware of some of the activities of the NGOs, and at the same time doesn't have oversight of the response to the refugees. So of course that's the role of UNHCR in context. But there's often not enough information. There is the cluster system operating, which is I think a key mechanism for accountability, because they have responsibility for reporting on all activities and monitoring well-being. But I think that there needs to be a much better involvement and sharing of information between the humanitarian and the governmental sector, and the humanitarian and the development sector. I think those are a main area. I would also argue that those who are working in country on research should have involvement at the table as well, because they're often familiar with the context and some of the issues at stake.
Thank you very much, Jocelyn.
Maybe I can add to this.
Yeah, please. Is that Joy?
Sorry, this is Liz here.
Oh, Liz, please, go ahead.
It's Liz here. It's just to say for the IAP, this is a very, very pertinent question. Our report this coming year is going to be on humanitarian settings and accountability mechanisms in humanitarian settings. And we will be looking into the question, so I don't have answers at the moment, but we will be exploring the issues around the accountability mechanisms in conflict settings, partially looking beyond the data as to who has the responsibilities, how the mechanisms for accountability can actually be strengthened. So any inputs from any members, and during the forum we will actually want to hear from people in this respect. Thank you, Liz. It's a very timely objective for the IAP. I think we're all looking forward to that. I certainly am. We have another question from Alex Shankland from IDS in the UK, who is asking, and embedded in a longer message, if you see it in the chat, but essentially he'd like to ask all of the panel, actually, what suggestions you have for strengthening synergies between the different types of accountability that have been discussed here today to improve maternal, child, and adolescent health. So the question really is about how do we strengthen synergies between all the stakeholders in all these contexts to try to pull the accountability question
together. Joy, I'd like to put you on the spot and start with you on this one, and then we can see who else would like to speak into it.
Yeah, thanks. And, I think some of this is like in research where you have multiple disciplines. You may be talking about the same thing, but it sounds very different, maybe with an anthropological angle or a quantitative angle or a financial angle. So some of that is the strength, I think, of this conversation. We have lots of disciplines from the parliamentary end or the quantitative data or thinking about accountability from the private sector or in specific contexts. So some of that, I think, is what the discussion about will be at PMNCH, because for keeping women's and children's health as a high-level topic, we do need to have a way that we communicate clearly enough on what the ultimate goal is. So the survival for women, children, adolescents, newborns around the world, thriving, opportunity for having your circumstances transformed, and enough of core data linked to targets so that we can be very clear about the gaps. But then on the next kind of level down, I actually think it's a great strength if we have lots of different angles and we're able to listen to each other, because we need both the political and the social and the data. We need all those components. So I think it's both a challenge and also an opportunity for much deeper accountability. I do think we're in a much busier, more messy world, and I don't know, maybe Liz can comment on this, but the structures for accountability that could help that common higher level language and communication seem much more fragmented in the SDG era.
Thank you, Joy. Liz, did you want to comment on that?
Yes, Yes, just to say that as I tried to mention at the beginning of my presentation, everything that is being said in this session all links into that framework on accountability. So I think that maybe what we need to do to answer your question on synergies between the different types of accountability is, first of all, say they're not different types of accountability. There are different components that come together to frame accountability. And what we will work on for the forum is to have maybe a better diagram to show how everything is interlinked. Because whether it be the parliamentarians, whether it be the governments, whether it be the citizens, they all need to have the data. They all need to understand the data, and they all need to be involved in the actions. So the remedies and the actions there will be some that are undertaken by parliamentarians themselves. There will be some that are undertaken by citizens themselves, and so on and so forth. So I think that if we have presented and it looks like there are different types of accountability, then we will need to relook at the messages that we're giving, because what we want to show is that they're all linked and they're all part of the same framework of accountability. But inherently, in order to explain what the data is needed, you need to have a presentation on data. But the data links into the bigger framework on accountability, and so on and so forth. So I hope that helps in understanding somewhat the synergies of the components of accountability, rather than calling them different types of accountability.
I think that's very clear, Liz and Joy. Thank you both very much. We have another question from Claudia Conlin. And Claudia, as Marta is also indicating in the chat box, I'd like to ask you to speak, if you would unmute yourself and perhaps explain your question a little bit. What accountability do countries have in using volunteer CHWs to build community public health systems? If you would just elaborate on it a little bit. And then, Elisa, I'd like to ask you to perhaps respond to this question, as it's about government accountability, I think. So, Claudia?
Hello?
Yes, Claudia, go ahead.
Yeah, I wanted to get at, we're talking now about universal health coverage and in our aspirations, global universal aspirations for the next decade. And we continue to see governments that are using poor volunteers to build the community component of their health system. And these governments are ultimately responsible as duty bearers. To me, it has always seemed inequitable, and there has been discussion about this, but not any discussion today.
Okay, I think we've got it, Claudia. Thank you. Elisa, would you like to respond to that?
Well, that I believe is a question that can somehow be tackled by all the presenters, because it's really again linked to how we create synergies between the different components of accountability. It's not just responsibility of civil society, it's not responsibility of researchers in the production of data, it's not responsibility of parliamentarians, but it's again trying to create what Liz mentioned, that diagram, to see how all these things are interconnected. I don't think any of the stakeholders that we have been discussing today will be able to address somehow the need raised by Claudia, but it needs to be an action done in synergies between the different stakeholders. I think, as you said, Dan, well, after this session, it would be very interesting to somehow even focus the session at the forum in order to address all these issues that have not been tackled today, like the one raised by Claudia.
Great, thank you, Elisa. I might just add a little bit to this question also, Claudia. It's a very interesting way that you've phrased it, and I think that citizens, of course, should be concerned with how government provides a service and how other service providers provide services as well, and what the nature and quality of the community linkage into the service systems is, and whether it's equitable, whether it's fair, whether citizens are being treated fairly. But at the same time, I think we can recognize that communities themselves have a responsibility and a role to play in their own health and nutrition outcomes as well. And so there are points at which some people believe it makes sense for volunteers within communities to engage a level of services within their own communities, recognizing that remuneration and incentive are extremely important aspects of a community health worker functionality and support, and do need to be addressed, whether it be within the community itself or third-party stakeholders or the government. So it's a bit of a complex and dynamic question that needs to be taken on the ground and through careful analysis, I think. We have another question from Hassan Ali, who is saying that there are lots of INGOs involved in low and middle income countries and doing huge contributions, but as well contributing areas that are not priority for the local communities. And people still have the worst health indicators. How can these be solved, or make an action of accountability for these institutions, being the INGOs? Marta, could I ask you to speak to this, as you had made some comments about intermediary INGOs working in this space as well? Maybe you can speak to that. And please feel free to speak to the CHW point as well as you proceed into that.
I think that's a great question, Hassan. I feel like that's maybe the most challenging one. I think that the issue of INGOs and accountability is really one that's raised repeatedly as a challenge, but not one that we've done a lot of concerted thinking about how to actually operationalize and address. Perhaps those on the participating here who work for international NGOs have more to say or some examples of actually operationalizing that, but I think it remains a real challenge. And there has been some work on the more macro level looking at accountability of donors and agenda setting and where that goes wrong. And I think it just continues to plague the field that we have a very sort of top-down agenda setting process in many contexts. So I don't have a great answer for you, but I agree that it's a big problem. Just to quickly respond to Claudia in a way that I think also gets at some of Alex's question and try to sort of draw some threads among the multiple things that were said. I think one way of looking at accountability rather than trying to come up with different typologies is to think about it as an emergent property or sort of overall characterization of the health system. And that means looking at strategy differently and considering the political capabilities of actors involved in social accountability, thinking through questions of links among different types of NGOs, so having grassroots NGOs that are more community-driven, working with NGOs as intermediaries that have more political capabilities, and then also using these skills to explicitly engage not only technocrats, but also political actors, and thinking more creatively about going beyond the health system. So looking, for example, at human rights institutions and other actors, the judicial sector and other actors who may have some ability to shape the situation when it comes to health. Claudia, on the CHW question, I think that's a really important question. I think it, again, points to the importance of thinking about accountability as a 360-degree issue. So rather than just thinking about duty bearers and rights holders, to think about people who work within the system as being rights holders as well, and understanding how intertwined their rights are with those they're serving. So if you have a professionalized cadre of CHWs, for example, or nurses, they often in situations where they are under-supported, under-remunerated, undervalued, they may provide a similar service to patients or the communities they serve. So I think accountability to all these actors is intertwined. So I can send you some resources offline on this issue. There's been a lot of thinking about trying to understand CHWs as accountability actors as well as accountability to them, and the same for nurses and other frontline providers. So thank you for the question.
Thank you, Martha. Thank you, everybody, for your questions. Miriam, thank you for your last question in the chat box there. Unfortunately, we are now out of time. I'm going to hand over to Sarah to just make some closing comments. But again, I want to thank you all. I hope that we will see many of you in New Delhi, if not all of you, and we will take these discussions forward in greater detail in the sessions that we have dedicated for this. So once again, thank you to all the panelists. Thank you to all the participants today. Really wonderful discussion.
And I will take a moment just to echo my thanks to our panelists, but also to our participants. Thank you for the lively chat here in our Q&A, and thank you for all of the wonderful resources that have been shared in the chat box. The recording of this session, this slide deck that has been shared, as well as links to the resources shared in the chat, will be posted on our Partners Forum website, which you can see there's a link here on this screen. In the next day or two, we're trying to get them up as quickly as possible. You will also receive an email at the end of this webinar series that will give you links to all of the resources from this 5-part series. If you go to, you'll also have, with this slide deck when you receive it, the Twitter handles of our participants. So if you can continue this dialogue via our social media channels moving forward. Tomorrow, we have our next session of our Partners Forum virtual series. We were going to be talking about the 7 habits, the 7 deadly sins of global health partnering, and also looking at best practices and lessons learned in global health partnering from a few of our PMNCH partners and speakers. So we hope that you will join us for that webinar. You should be receiving a reminder email for that today with those links if you don't already have it noted in your calendar. So again, thank you so much for being here. Take note of the links here, and we hope to see you in Delhi and online. If you aren't going to be in Delhi, please join our virtual forum where we're talking on Twitter and watching from afar. So thank you for participating, and we look forward to seeing you next time. Bye-bye.